Hey everyone, and welcome to This Explainer. Today, we're taking a seriously fascinating journey through the sheer scope of the nursing profession. We're going to start way down in the high adrenaline, microscopic environment of the heart's electrical grid, and then we're going to zoom all the way out to macroscopic community and public health. It is an incredibly wide spectrum of care, and we're going to break the whole shebang down step by step.
Okay, let's dive right into this. Here's our roadmap for today. We'll explore the heart's electrical grid, jump into critical interventions like meds and CPR, break down the cascade of shock, and finally, shift our lens over to community nursing and protecting vulnerable populations. Starting things off with Section 1, the heart's electrical grid. Think of every single heartbeat as this incredibly precise electrical symphony. It all kicks off with the P wave, which is your atrial depolarization. Then, the M pulse travels during the PR interval. Now, this takes just 0.12 to 0.20 seconds, literally the blink of an eye. After that comes the big squeeze, the QRS complex, or ventricular depolarization, which happens in less than a fraction of a second. And finally, the T wave shows the ventricles resetting. Knowing these split-second intervals inside and out, that's your baseline for spotting when disaster strikes.
And believe me, things can go wrong very quickly. When the ventricles get irritable, we see these rapid, chaotic patterns where the heart just completely fails to pump enough blood. You've got ventricular tachycardia showing wide QRS complexes at a really rapid rate. Then there's ventricular fibrillation, which is pure chaos, no pattern, no pulse, just quivering. Asystole is the dreaded flatline, an absolute absence of rhythm. And PEA, pulseless electrical activity, that one is incredibly sneaky because the monitor actually shows a rhythm, but the patient has zero detectable pulse. In all of these scenarios, oxygen drops fast, and time is quite literally tissue.
So when you're staring down a lethal rhythm, especially PEA or asystole, you have to play detective. The H's and T's are your ultimate troubleshooting guide. You have to ask yourself, is it hypovolemia from blood loss, hypoxia, maybe a tension pneumothorax? Reversing the cardiac arrest means you have to rapidly identify and fix the exact H or T that is causing the crash.
Which brings us to Section 2, meds, pacemakers, and CPR. When the heart's grid fails, we call in the heavy biochemical hitters. Adenosine is basically a reboot button for supraventricular tachycardia, but it requires a very rapid IV push and immediate flush. Amiodarone acts as a potassium channel blocker that slows things down, making it a go-to for life-threatening VTAC and VFib. Then you have epinephrine, your main vasopressor for managing full cardiac arrest to maintain heart rate and blood pressure. And finally, atropine steps in to increase the heart rate when a patient is stuck in a dangerous, sluggish bradycardia. But, sometimes meds just aren't enough to do the trick. When a patient has a severe third-degree heart block, where the atria and ventricles are totally disconnected from each other, or if they have chronic conduction defects, mechanical pacing steps in. A pacemaker literally generates an electrical pulse to stimulate the heart. It can operate on demand, so it only fires when the natural heart rate drops too low, or it can be asynchronous, delivering a steady, reliable beat regardless of what the patient's own heart is doing.
Of course, in a full cardiac arrest, everything comes right back to the standard CPR protocol. Step 1 always is assessing scene safety. Then you call for help and grab an AED. Step 3 is jumping into high-quality CPR. But the true test of your clinical reasoning happens in Step 4. Once those compressions begin, your ultimate background priority is hunting down that underlying cause. Yep, bringing us right back to those H's and T's.
All right, let's move on to Section 3, the Cascade of Shock. So physiologically speaking, what exactly is shock? Well, it is triggered by a sustained drop in your mean arterial pressure, or MAP. Remember, healthy blood flow relies on stroke volume, heart rate, and systemic vascular resistance all working together perfectly. When your MAP drops significantly, blood flow just plummets. At that point, the body literally begins to starve for oxygen at a cellular level, and that happens regardless of how much oxygen is actually sitting in the lungs. This devastating cascade happens in 3 progressive stages. In stage 1, or pre-shock, the body is compensating. The sympathetic nervous system kicks in, bumping up the heart rate to try and fix the drop so the outward symptoms stay pretty subtle. But if MAP keeps falling, the urgency spikes big time as we hit stage 2, progressive shock. This is a critical threshold. The cells are so starved for oxygen they switch to anaerobic metabolism, which pumps out lactic acid and causes cellular swelling. If you don't fix the underlying cause immediately right here, the reality becomes grim in stage 3, multi-organ failure. At this point, widespread tissue anoxia leads to irreversible cellular and organ death. To actually treat shock, you absolutely have to identify where it's coming from. Hypovolemic shock means the tank is empty. We're talking an intravascular volume loss of 15% or more from something like trauma or severe burns. Cardiogenic means the pump itself is broken, like in a massive heart attack. Distributive shock is widespread vasodilation. This covers your septic, anaphylactic, and neurogenic shock from things like spinal cord injuries. And finally, obstructive shock happens when there's a literal physical block to blood flow, like a pulmonary embolism or cardiac tamponade.
Let's shift gears completely for Section 4, Community Nursing and Prevention. Okay, we are zooming all the way out now. We are leaving the chaotic ICU and hitting the streets. Instead of treating a single failing heart, public health nurses use what's called the epidemiological triangle to measure the burden of disease on an entire population. They are actively looking for ways to stop an illness in its tracks before a patient ever even needs acute hospital care. Think of this triangle like a giant puzzle with three main pieces: host, agent, and environment. The host involves factors like age, gender, and someone's baseline immunity. The agent could be an infectious virus, a chemical toxin, or even a physical hazard. And the environment? That covers physical things like water and food supply, but also the social environment, things like poverty, workplace hazards, and basic access to healthcare. By figuring out exactly how these three corners interact, community nurses can pinpoint the perfect spot to intervene. And how exactly do they structure those interventions? Through the three levels of prevention. Primary prevention is all about maximizing wellness before an illness or injury ever occurs. Think along the lines of immunizations or teaching workplace safety. Secondary prevention is your early detection and screening, finding the problem while it's in its early active stages. And tertiary prevention comes into play at the palliation or end stage of a disease, focusing on rehab and restoring as much health as possible. This framework right here is the absolute strategic backbone of public health nursing. Now, to figure out what a community actually needs in the real world, nurses often do what's called a windshield assessment. It is literally exactly what it sounds like. A drive-through of a community, you're looking at the windshield and asking, who is walking on the street? Are there grocery stores, or is it a food desert with just fast food? What is the housing quality like? Is there public transit? It is a brilliant, practical way to identify real-world barriers like geographic isolation and poverty that directly dictate a community's health. And that perfectly sets up Section 5, Protecting Vulnerable Populations. So, initiatives like Healthy People 2020 identify specific groups that are super vulnerable to falling through the cracks of inadequate healthcare. The homeless face severe poverty mixed with mental health crises. Rural residents battle extreme geographic isolation. Migrant workers often run into profound language and cultural barriers. Veterans face really unique risks for PTSD and traumatic brain injuries. Across all of these distinct demographics, nurses have to step completely outside the traditional hospital caregiver role. You basically become a fierce advocate, educator, and case manager. Let's ground this in a real scenario to show you what I mean. Imagine a pregnant teenager who lives 2 hours away from her OB/GYN and a full 2.5 hours from the nearest hospital. How do you even begin to plan care for her? You see, this isn't just a clinical problem anymore. It's a massive environmental and access problem. A community nurse has to apply those levels of prevention to that severe geographic isolation, finding totally creative ways to provide primary education and secondary screening when traditional healthcare sites are basically miles out of reach. Or consider a veteran who just returned from deployment and is experiencing intense night terrors. In a situation like this, your priority is targeted secondary prevention. The trauma isn't always physical, right? Sometimes the absolute most life-saving intervention a nurse can provide is recognizing the unseen psychological agents affecting the host, and doing that through rigorous PTSD and suicide screening. To actually manage and support these vast populations, nurses fill incredibly diverse roles outside the hospital walls. Home health nurses are out there managing complex care and running IV medications right in a patient's living room. Hospice nurses focus on palliative, end-of-life care, heavily prioritizing dignity and symptom control. Occupational nurses actively promote workplace safety. Faith community nurses blend holistic and spiritual support. And school nurses act as vital case managers and counselors for the next generation. Wow, we have covered some immense ground today. From tracking chaotic, lethal electrical blips on an EKG monitor, all the way to mapping the socioeconomic barriers of an entire community looking out a car window. The scope of nursing is truly limitless. So I'll leave you with this final thought. How will you bridge the gap between treating the individual crisis right in front of you and advocating for the broader public health of the community around you? Thank you so much for joining me on this explainer, and keep asking the big questions.